talk to you guys today about ECOG. I have practices that actually have evoked potential equipment, and they do more ECOGs, and now VEMPs as well, than they do ABRs. I have some practices who've never done an ABR. All they've ever done is ECOGs with it. And maybe we'll see the reasons why. So this is not something new. See, these two studies are from way back in 1930 even, when it was electrocochleography was first introduced in the literature. Okay? So it's been around for a long time. And I guess the big question is, why would a doctor order electrocochleography? And by the way, this is the way it is normally abbreviated, ECOG, even though you'll also see it as ECOG. But this is the official abbreviation for it. Okay? Well, why would a doctor order it to begin with? Well, because, here's the answer, he wants an objective confirmation that the patient has what he suspects they have, Meniere's disease or endolymphatic hydrops. And this condition is relatively common. It's an inner ear disorder that affects both balance and hearing. And there are other disorders that can affect both balance and hearing, like an acoustic neuroma, for example. What actually happens here is a part of the semicircular canal called the endolymphatic sac becomes swollen. And this sac regulates fluid pressure in the canals. So excess fluid is what results from this. And that physically causes this condition. And it can result from a head injury or a middle ear infection, syphilis, allergies, alcohol use, stress, smoking, even the use of aspirin. So it's quite a common thing. And sometimes the symptoms are a little ambiguous. And the doctor wants confirmation that it is in fact Meniere's disease before he starts treating the patient for that. Okay? So, that being said, this is a test that many physicians would like to do. And many of them have tried it and not been successful in the past, and so they don't do it. Others who have been successful, either currently or in the past, seem to order it quite a bit because of how common these conditions, these symptoms might be. So anyway, that's why it would be, for a patient that does workups on dizzy patients, to add to whatever they're doing as a vestibular workup, to add maybe the diagnostic neurological ABRs, to add VEMPs, which we talked about before, and to add electrocochleography makes a lot of sense in order to assist the physician in his differential diagnosis, what's going on with the patient. So let's just talk about this test and how we can do it successfully on almost every patient. Okay? First of all, it's a one-channel test. There's no need for a contralateral channel or anything like that. The most common way that people want to do it is with tiptoes. That's these. And we'll talk about that and show these in some more detail. This is a non-invasive technique. This is a tiptoe is an electrode that fits down in the ear canal. And there are other methods to do it as well, and I'll show those. And as far as electrode montage, there are two possible montages. One is vertical and one is horizontal. The horizontal montage is best. That means that we are collecting the signal between the two ear canals, like this, instead of from the forehead to the ear canal. This would be more vertical. This is more horizontal. And when the more vertical the electrode array is, like so, this would be perfect for ABR because we're interested in the amplitude of wave 5 being as great as possible. But in this case, we're interested in the amplitude of wave 1 being as great as possible. And so the closer to horizontal it is, the higher the amplitude of wave 1. So that's why I have that the best montage, electrode montage, is horizontal. And if you want the action potential, that's like wave 1 in the ABR, if you want that to go up, to be positive going, right, then the test ear, the ear that's being stimulated, because this is an ipsilateral response, the test ear is either reference or input to or negative, depending on which piece of equipment. That's very important to know. And it is true of ABR as well. If you want the waveforms to be positive, the peaks going upward, in this case the one peak is the action potential, it's wave 1 of the ABR, then the electrode that needs to be on or in that ear is the reference electrode, or input to, like biologic would call it, or the negative electrode like you would have on an Audiology. Okay? And the other ear is the other electrode. It's the active electrode, or input 1, or the positive electrode. Okay? So that has to be known. And what it's called, it should all be called the same thing. The best thing would be just to be called the reference electrode, but because manufacturers can't agree on that, you have to know that. And then the ground is on the forehead. So we're collecting between the two ear canals, ground on the forehead. Okay. It is an auditory evoked potential. Just like the ABR is an auditory evoked potential, like the middle latencies are an auditory evoked potential, and late responses in P300s. They're all auditory evoked potentials. This is the earliest of them. The response occurs around 1.5 milliseconds. Okay. And here it is. Now this is a negative going action potential, which is the way it's measured in almost all the literature, even though audiologists like to see it the other way around because they're used to that in their ABRs. ECOGs have, in the literature, you'll often see them like this. All right? If you flip this around, and we'll show you some flipped around, then of course it'll be positive going. So the most obvious peak is this. All right? It's negative in this example, and that's the peak of the action potential. The actual firing of the 8th nerve. That's what we call it, 8th nerve action potential. 8th nerve is the auditory nerve. And so we look for that first. And if we follow that to its leading trough, that's this, okay, then right before that there's another small wave. In normal individuals it is quite a bit smaller than the action potential, and that's called the summating potential. And it's the ratio of amplitudes between summating and action potential that determines whether the ECOG is normal or not. But you see where this occurs? The peak of the action potential occurs exactly where you'd expect it to occur, at around 1.5 milliseconds at high intensity stimulus. Same place that wave 1 occurs, because it is, in fact, wave 1 of the ABR. Okay? Now here's something that's very important and makes the difference between success and failure. Okay? Here's a set of Tiptrodes. And it's very important to realize that the generator of this response is the cochlea. Okay? And no matter how we collect this response, it's going to be a far field response. In other words, our electrodes are far away from the generator of the response. And this response, especially the summing potential, this is the smallest measurable potential that the human body produces. We want it to be near field, but the only way we would make it near field is to have a needle electrode penetrate the tympanic membrane and sit right on the promontory, right here. Okay? That's the way we would do it. And that's the way it was done, even in 1930 on animals. But that's an invasive technique that most clinics wouldn't do. Okay? So instead, we put an electrode in the ear canal. We get it as close as possible. Not as good as going right here, but as near field as we can get it. And it makes a big, big difference. So what I'm trying to say is it is very important to bury that Tiptrode in the ear canal as much as you possibly can. Look at this slide. Okay, here's just the relationship in amplitude, right, on the y-axis, and with the depth of insertion. Okay, if we put our electrode on the mastoid right here, instead of in the ear canal, look how low our amplitude, the amplitude of the action potential would be. It would not be measurable or repeatable or anything. Not enough amplitude. When we go to the earlobe, it would be a little bit better, but certainly not good enough. When we go to the ear canal, we're getting better. That's why we're in the ear canal. We're closer field. And the further we go, watch what happens. You see, once we get in the ear canal, the curve starts going up pretty drastically. So the further we get down the ear canal, look, the greater the amplitude is. Once we get on the tympanic membrane, the eardrum, once we get on the eardrum, then we're here, you know. If we were on the promontory, we'd be way up here, all right? But let's assume that we're not using a needle electrode and doing surgery here. All right, well then the best we can do is a electrode that sits right on the TM. The next best we can do is just as deep in the canal as possible. So an audiologist using this technique with tiptrodes has to learn very deep insertion techniques with this. You see how I'm rolling this down using the smallest possible tiptrode, and I'm working this in the ear canal. And when it's in the ear canal properly, I can't even see it. Now I've got this inserted very deeply. I've cleaned the canal with alcohol and new prep and a Q-tip. So I've cleaned it and braided the external meatus in the ear canal, and then I've inserted this just as deeply as I possibly can and let it expand. And that's very important. Can't emphasize how important that is. I hope this helped emphasize it. Okay, so here's just a picture of the tiptrode. The tube, a tiptrode is a combination of an electrode wire, see, with an alligator clip, and it also has a tube that leads to the transducer, the insert transducer. So when somebody uses this, they take the tube off the transducer and they put on the tiptrode, which has a tube built into it. And it also has an electrode wire. So this is a tiptrode lead. I've connected the lead here to this right side insert. It's important not to leave the tube that's on the insert on there, because now you're going to add 1 millisecond of latency. Okay, that's how long it takes, about a millisecond, actually 0.8 milliseconds for the stimulus to run down the length of the tube. Okay. So there's the tiptrode, and I would use the small one on almost everybody unless he has a giant canal. There are small ones like this. They look like pediatric ear tips. But in this case, it's not pediatric. It's just small enough to get deep enough in the ear canal. I'd use these on almost all patients. And then these tiptrode leads have an alligator clip in it. You squeeze this as you insert that so that the alligator clip actually grabs onto this gold foil. This is 24 karat gold painted foil. Okay. Trying to get as good electrode impedance as possible in the ear. There are the larger ones, and I wouldn't use those unless I had pretty big ear canals, because I'm going quite deep. Okay, here's the protocol, which you can set up on any piece of equipment. The stimulus is clicks. All right. There isn't that much of a good defense of using tone bursts for this. Okay. And the typical duration, 0.1 milliseconds, so that's standard on all equipment. It needs to be a low rep rate. If you try to do this at a fast rep rate, just like you would in an ABR, you would lose wave 1, you will lose this. Quick rep rates, very rapid stimulus, is fine for ABR when you're trying to do it in a hurry and all you care about is wave 5, you're looking for threshold. But it's not in something where what you care about is wave 1. That's the action potential in our waveform. So it needs to be 7.1 or slower. The slower the better. 7.1 works okay on most people. And the polarity is very important too. It needs to be an alternating stimulus. If not, you will not be looking at the summiting potential. You'll be actually seeing a contaminated summating potential is contaminated with the cochlear microphonic. If you use a single polarity stimulus, it has to be alternating. That cancels the cochlear microphonic, and you're left with the true summating potential. Okay? So the polarity needs to be alternating. And the intensity needs to be loud. I always use 95. If you're afraid to use 95 because you think the patient will complain, then 90, but never lower than that. Okay? And of course the transducer is an insert. I would never do it with phones. Too much of a stimulus artifact, even an electrical artifact. And you don't need masking. It's an ipsilateral only response. Okay? So, continuing with the protocol, the gain, when you're using Tiptrodes, can be very close to the gain that you use for AVR. On a biologic type instrument where gain is specified like this, a gain of 75,000 or even 100,000 is fine. Okay? Close to the same, or maybe one notch lower gain than you would use for AVR. And the analysis time that you use for AVR in adults at least is 10 milliseconds. I always make my analysis time for ECOG less than that. I make it 5.1, 6.1, 7.1, something like that, rather than 10. So even if it goes down to 5.1, it would be fine. That's the analysis time, I mean the length of the window. And how many sweeps to do? You got to do at least 500. And if in 500 you have a good response that you can identify and read, and as you're watching the averaging continue and the screen updating with a new average, then you can stop. If it doesn't continue to change, if the waveform is changing every time it updates the average, then of course you can't stop because you haven't achieved a stable response yet. But at least 500, and then you can stop if you have a good response that isn't changing as the average updates. Filters are important too. The high-pass filter, or you could call it the low filter, the low end of the bandpass, needs to be 10 hertz or lower. That's very important in this, because this is a low frequency response. And if you make this 100 hertz, like you would for, say, an ABR in adult, you won't see the summing potential. So that's important. And there's no reason to go over 1500 or 2000 as far as the high end of the bandpass. Some manufacturers call this the low-pass filter. We never use a notch filter, all right? Because part of our response is 60 hertz. So we don't want to remove 60 hertz from it. So you have to do it in an atmosphere. I can't do it in this room, the conference room that we're recording this in right now. I can't collect an ECOG because there's too much 60-cycle noise in here. There's an electrically hostile environment. Can't have that. And then options on the electrodes are the Tiptrode that I just showed you, or a TM electrode that we'll see in a minute. Actually sits right on the tympanic membrane, okay? And lots of users swear by that once they practice enough, and they've got to have the guts to practice enough and become good at it. Then they'll swear by that because it's closer to the generator and therefore a bigger response. Easier to measure, less averaging, easier to repeat and to mark. And then of course the ultimate option would be the transtympanic needle electrode that sits on the promontory. Okay, there's that TM electrode. Okay, used to be made by Biologic, but since Biologic is owned by Natus now, they don't care, and they have discontinued that. Okay, little bias, but anyway. You want to edit that out, you cannot. But this is available now somewhere else. I don't exactly know where else, but
we carry it in intelligent hearing systems.
Okay, get it from Intelligent Hearing Systems? Okay. So that's perfect. I would put just a dab of gel, and I mean a real dab, and not something that's going to actually separate you from the TM because you have to be sitting on the eardrum. But at least a little bit of gel on the end of that, and then with practice, people get pretty good at it. These are the leads that you need for the TM electrode. Okay, what's the advantage? About double the amplitude, as you saw from the graph. Okay, so here's basically, see, this is a cochlear microphonic that you would get from condensation or rarefaction. Alternating cancels that out, and you have a true summing potential. And sometimes the summing potential is a nice discrete wave just before the action potential. In this case, it's just a little bump on the leading edge of the action potential. And so you're probably saying, Craig, could you flip that around and make it look normal for me? Okay. So this is the way most audiologists in the United States display their ECOGs. All you have to do is hit invert or switch the electrodes around. The montage I gave you was for a positive going action potential. So if you were marking this, a good method for marking it is find the action potential first. How will you know? It'll be about 1.5 milliseconds, unless there is a massive conductive hearing loss that will push it out. But at 95 dB, it'll be around 1.5 milliseconds if you don't have that conductive loss. And then once you find that peak, and this should be obvious and repeatable, once you find that peak, if you go down the leading edge, and the first thing you find there is going to be summing potential. And it's very common for this to be riding on the leading edge. Like as if this is a mountain peak and this is a foothill. And then the bottom of the foothill people use to mark it and call baseline. Some don't. Some actually take the actual 0 point, and they use the 0 point. On a biologic, for example, you can have the 0 point of the response, show the electrical 0 point, and you can mark it there. So some people will mark it there or here, right on the dotted line that represents the 0 point. Some will just mark it down in the trough. The point is, you're measuring a ratio. The ratio between this amplitude, okay, from baseline to the peak of the action potential, that represents the amplitude of the action potential, and then you're measuring the amplitude of the summing potential. So as long as you do the same thing, from the same place, I'm measuring to the peak of the summing potential, and now the ratio of those two amplitudes is what's important. The latency isn't so important. The latency is going to be consistent, except for a conductive hearing loss that would push it out. So here we've marked it the same way. Action potential, summing potential, and then baseline. Okay? Just in a negative going representation. Okay, so here's some normal ECOGs. And what you'll notice about the normal ECOGs, here's a left ear and a right ear on a biologic instrument. And you'll notice that the summing potential is much lower in amplitude than the action potential. It is less than half of the total amplitude of the action potential. Okay? That's important to know. In normal ears, the amplitude of the summing potential is less than half of the amplitude of the action potential. Okay? So I could look at this without measuring anything, without even marking it, and say, this is normal. If that's repeatable and consistent, then that's a good ECOG, and it's normal. And so is this. Because I don't have to measure anything to know that this is less than half of that. Okay? Make sense so far? Good. All right. This is just showing you what you would get. I don't have a good slide of this, so sorry about that. But what you would get if you used a single polarity click, like a rarefaction click. See, that looks like it's a summing potential there, but it's actually contaminated by the cochlear microphonic, as the microphonic mimics the stimulus. Okay? Use an alternating click, that is canceled out, and you have the true summing potential sitting there. And then once you do, if you did the calculation, and all the machines do it, of the AP-SP ratio, the ratio of amplitudes, you would get 0.4 or 40%. All right, and I'll tell you what's normal and abnormal in a minute. So let's look at some normal ECOGs on different pieces of equipment. This is on the Audera, the Grayson Stadler Audera. By the way, the Audera does an excellent job. Biologic does an excellent job. The Audera does an excellent job. The Eclipse does an excellent job of actually acquiring and displaying ECOGs. So here, action potential, exactly where we'd expect. Look, 1.57 milliseconds. As long as this is repeatable, and is it? Yes, yes. See, 3 responses, nice and repeatable, lining up perfectly. Nobody in this world would doubt that that was the action potential. It's not some kind of artifact. And then, if we find that peak first, and then go down the leading edge until it makes its move to the left, and that's where we're marking the summing potential, and then the bottom of the summing potential, that's the baseline. So we've marked this one, and we've marked that one, and the machine will calculate the AP-SP ratio. And this one would be obvious too. Nobody would doubt that that's the action potential. Nobody would doubt that that's the summing potential, and most people would mark the base down in that trough there. This I don't like. If I see these, I don't mark them, because you didn't have a baseline recovery here. Sometimes the baseline, especially if there are artifacts, if they have a myogenic artifact, muscle artifact coming from the patient, it all depends on how calm the patient is. If they go to sleep, then you can get some beautiful ones, right? Because the EEG goes way down. Remember, the summing potential is one of the smallest measurable potentials the human body makes. If you see this, I just don't take it. I delete it, because you just haven't recovered. The baseline hasn't recovered here. A lot of times they start out like this, but they end up like these. This is what you want. Maybe average longer. Sometimes if it's like this, if you continue to average longer, it'll come down. Sometimes it's not worth it. Just start. And this is what is in the charter for. This is what's in the charter for an actual example of an ECOG. And this one is correct. Okay. Sometimes the summing potential is so small that you can't see it on the ledge there. You can't see it. There isn't a definable bump. All right. And then you have to kind of use your imagination a little bit. That patient is normal, because when the summing potential is so small that you can't even see it, okay, the patient is normal. All right? When they're abnormal, when that summing potential is greater than half of the action potential. So this is so small that I can hardly see it. And I'll give you a trick of a way to do it. If you mark the action potential and go back about a half a millisecond, 0.5, 0.6 milliseconds, you'll be close to it. There's about a 0.5 or 0.6 milliseconds in between the summing potential and the action potential. That's a good key tip to know. All right? So, and then mark the baseline maybe at this point here. Anyway, this one's fine, and this one's fine for the other. It is nice, well-defined summing potential and baseline. But this one, this is bogus. I wouldn't mark this. This isn't in the right place. It didn't repeat with this one, first of all. And it's way out there past 2 milliseconds. That's not the action potential, okay? Unless that person has a pretty big conductive hearing loss, and then they shouldn't be tested, because you can't get a good response if that was the case. This is just bogus. This one just doesn't look clean enough. I would have to make sure this repeated. If this is a repeat of this, which it looks like it is, it hasn't repeated. So I think I'd be dumping these and doing them over. But the top ones I love. Okay, so that was the Charter EP. Actually, the Charter EP is a little bit, it has noisy processing in it. You won't get as clean a results as you'll get with Biologic or the Eclipse or the Audera, okay? Just because it has noisy processing, especially the current unit. Okay, what? What's the question?
I was just looking at the notes on
They were-
how they collected the data was different.
Oh, they collected them different. Oh, one with a TM
Yeah,
electrode
one
and the other.
With-
Okay, so 3 and 6. All right, good demonstration. 3 and 6 were collected with a TM electrode. Is that what it's trying to say? And 1 and 2 with tiptrodes?
Yep.
Well, then I would bet you anything. These are all on the same scale. Okay? I'd bet you anything that these weren't on the eardrum. You know, because the tiptrode response is better. You know, and it should be very clearly better, the TM electrode response, higher amplitude. I don't think they were. And that happens very often. People use a TM electrode for the first time, and it's not even sitting on the eardrum. Okay. And if you don't know for sure it's on the eardrum, then you have a problem. Now this is the biologic, and here's one very obvious. This is beautiful, classic. It should be in a textbook. Here's the action potential. Move down, can't miss the summing potential, and they found the leading trough of the summing potential and made that the base. An alternate method they used on this one. Okay, they took the action potential, no question there. Summing potential, no question there. Where's the baseline? They could have gone down here with it, but instead they decided to use the electrical zero. This dotted line across here is electrical zero, the electrical 0 point of the waveform. All right, and they found a place close to that, and they marked it there. That method's fine too. Just be consistent in what you do. Okay. Most people would mark it like this. Okay. And why are these here? Very often, clinics will do 2 runs and then take the average. The machines will do averaging, and they'll take the average, or some of the machines call it adding. And so you average these 2 together and you get something gorgeous like this. Okay. What about hearing loss? This is the biggest problem for electrocochleography. And so, if you had a situation like this, the left ear is normal hearing, right? Thresholds are 5 and 10 dB, or 10 dB basically, 10 and 15, within the normal range of hearing. And then the right ear has a sensory neural hearing loss that is 60 dB at 2 and 4K, or 3 and 4K. So there's a high frequency sensory neural hearing loss here. And here's the ECOGs. On the good ear, the left ear, right? Beautiful ECOGs. No problem at all. Look at the right ear. Not there. Here's wave 5 way out here. But there's nothing, and if somebody was crazy enough to mark this guy, well, mortal sin. Because that's not even, look at it, it's -1 milliseconds, right? It's not a response. It's a click, a stimulus artifact. It's not even a response. There is no response. No, there is a wave 5. So if you were looking for hearing threshold, okay. But there's no wave 1. So you have to know that the thing that makes this test invalid, what may be a reason not to do it, that would contraindicate it, would be sensory neural hearing loss. Okay. Now you say, what does an abnormal ECOG look like? I know that was your question all along. Well, here's a good slide that shows normal versus abnormal. And what's the first thing you notice about the abnormal one? Look at where the summing potential is, way up here. Okay. Now the ratio is going to be much greater than 0.5. The summing potential is more than half the total amplitude of the action potential. Okay? So that's, I wouldn't, if I looked at this, I'd know it was normal. Without marking or analyzing anything, if I looked at this, I would know it was abnormal without marking or analyzing anything. And they did 2 of them and took the average. That's what they did here. Did 2 of them and took the average. Which is a very good way to do it, by the way. Okay, so here's some great rules of thumb to know. This is probably the best slide in your handout. The action potential is the thing to find first. That needs to be obvious, where I wonder if it's there or not. Well, if you have to wonder, it's not there. It should be obvious. You'll find it first and mark it. It'll mark AP on the equipment when it's set up for econ, and it'll be around 1.5 milliseconds, just where you expect it. The summing potential will be about 0.6 milliseconds prior to the action potential. So that's going to come in around 0.9 in this case. All right? That 0.6 is important to know, because if you can't find it, well, find the action potential. Because if you can't find that, then you don't have a response. But find the action potential and then move back 0.6. Now you're very close. Move back 0.5, 0.6 milliseconds, and you're real close to it. Okay, that's good to know. Good trick. Now, where's the baseline? If you happen to be on the summing potential and you move back another 0.6, you'll be very close to the baseline. Okay, they're just rules of thumb. That 0.6 trick is just rules of thumb to help you mark it. All right. And what's normal? Another important question. The AP-SP or SP-AP ratio is calculated by the machine. You don't have to do the division. But normal is less than 0.53. Okay? What a lot of clinics use. You can round it off to 0.5 if you want. Well, 0.53 is a good choice. And of course, 0.53 and 53%. Same thing. In other words, the summing potential is 53%. The amplitude of the summing potential is 53% the amplitude of the action potential. Okay, over half. Okay, now how good a test is this at predicting Meniere's disease? Well, 63%. If you don't test the patient when they're having an active symptom. Meniere's disease, the symptoms are episodic. The patient has episodes. He's not always in an episode. So what if you're testing the patient and he's not in an episode? Which will probably be the case unless you get real lucky. Oh, you're sick? You're throwing up? You're dizzy, you can hardly walk? You're nauseous? Oh, come in. I want to do an ECOG on you because you're symptomatic now. I have now up to a 92% chance of a positive result consistent with your Meniere's disease. Okay? And that would be it, 92%, if you did it when they were symptomatic. But if not, then 63%. I'm going to show you a way to get that up to 83%. Okay? So hang on here. Here's some other things that are important. I have seen clinicians insert the Tiptrode without cleaning the ear. But naturally, to clean the ear canal, and to clean it as deep as you're going to put, it takes a little practice because you're going to put that thing real deep. You're going to try to sit it on the eardrum. So you have to clean the ear canal with alcohol with a Q-tip. And you've got to get down there nice and deep. And I put a little bit of new prep, just a little, not enough to create an obstruction in the ear canal that's going to clog up my Tiptrode and diminish my stimulus. That'd be the worst thing that can happen, but just a little bit of new prep right on the what do you call it? The Q-tip, so that I can not only clean and degrease the ear canal, but also abrade it with the new prep. Okay, that's important. Use the small Tiptrodes to get it as close as you can, the deep placement. And then to insist with the doctors, to insist on a 2K40 or 2K60 rule. Okay? And what I mean by those are how much hearing loss can you tolerate and still do this test? Right? If they send you a patient, like the patient that we just saw, where the ear with the high frequency sensorineural hearing loss, with the thresholds in the high frequencies, were really too great to get a response, then what's the sense of doing it? All right. So to devise some kind of rule, doctor, look at the threshold at 2K. 2K happens to be the center frequency or the fundamental frequency of the stimulus, the way it's presented. If you look at the audiogram and the threshold exceeds 40 dB, and a lot of people say 35, at 2K, well, it's contraindicated. There's too much hearing loss to get away with Tiptrodes. You might be able to get it with a TM electrode. So change your rule to something like a 2K 55 or 60. All right, the threshold at 2K can't exceed 55 or 60 with a TM electrode at 2K. If you do that, there'll be some people with a threshold of 40 at 2K, and on Tiptrodes you can't get a repeatable. When you can't get a clear repeatable action potential, you don't have a usable response. The only thing that's going to cause this is too much hearing loss. So those are two good, convenient rules to use. All right? And of course, if it doesn't replicate, you must investigate. I didn't invent that. Jay Hall did. But that's a very, very good thing. You know when he said that? He said that in the middle of the O.J. Simpson trial. When Johnny Cochran said, if the glove doesn't fit, you must acquit. Well, the next morning was the second day of an evoked potential class here in Stone Mountain, Georgia. 120 audiologists in attendance, and everybody went home that night and they watched the O.J. Simpson trial because there was nobody in America that wasn't intently glued on that. And so they all heard Johnny Cochran say that. And then he comes in the next day and says, if it doesn't replicate, you must investigate. And it was funny to us at the time because nobody missed the trial that night. Okay. So, all right. Here is a question for me. A customer of ours, Middle Tennessee, ear, nose, and throat, Murfreesboro, Tennessee, faxed this to me. Okay? It wasn't long ago. And this side is fine. So on the right ear, very easy. No doubt of where to mark. And the patient's younger than me, right, with normal hearing. So no question where the action potential is. The summing potential is a little bit ambiguous here, but you can see this bump. And if you look at some of the replications, they did several of them and averaged them together. You can see it there. It lines right up, baseline, everything clear. That's totally normal. No need to even do anything. And the action potential, look at this, coming at 1.53, 1.53. And the AP-SP ratio, 0.38, 0.25, altogether normal. All right. On the other side, though, they said, man, I'm marking the AP here because it's my first wave. And then where's my summing potential? Is it way out here? That was their question. What do you think?
I think they got something placed wrong. Or they have a lot of hearing loss.
It could be conductive, so much conductive hearing loss that it pushed this way out here and obscured the summing potential. That could be, but it wasn't. The hearing was normal on both sides, no conductive hearing loss.
The waves are
normal temperature.
The waves are inverse.
Right, this is inverted. This side is inverted. This is the action potential. Look at the summing potential. Beautiful summing potentials that are no problem. The summing potentials were very, very clear there. So I wrote on this, is it possible that in the left ear, the waveform is just inverted? And right away she sent me a text going, oh, why didn't we notice that? They didn't change their electrodes. And this would be easy enough. You wouldn't have to do it over. You just hit invert on the machine and flip it around. And everything would be fine then. You would mark it totally differently. This is the trough of the action potential that they're marking, the peak of the action potential. Okay. This is upside down. Okay. So how could we, here's the problem though. Sensitivity, 63%. That's no good. Sensitivity of 0.63. Ideal is 1.0 or 100%, right? So how could we do better, even when the patient is not symptomatic during the test? Okay, here it is. It is an area measurement. Instead of just measuring the amplitude of the summoning potential, comparing it to the amplitude of the action potential, instead of just doing that, we're also going to measure the area, not just the amplitude, but the actual area of the summoning potential and the area of the action potential, and compare those. All right? And we're going to find on normal patients that this is what we get. 1.0 to about 1.75. A standard deviation of 0.3. Not bad, right? And so we're going to conclude that normal is lower than 1.94. Okay? And that's the area ratio between the summoning potential and the action potential. Now we've increased the sensitivity, or the positive predictive value, to 83% instead of 63%. Voila, we make this test a lot better if we could do that. And there is one piece of equipment that actually does, and that's the Inter-Acoustics Eclipse. Built into it, no extra charge, into the ECOG software, is the ability to measure the area. It used to be called area under the curve. And it looks like this. Now, this is negative going, so don't let that throw you off. Okay? But we're actually going to mark 4 points. Okay? Well, 5 if we mark the peak of the action potential. But in this case, we don't care about the peak of the action potential. We care about both of the troughs, the leading trough of the action potential and the ending trough of the action potential, and the trough of the summing potential, or we call this normally, we call this the baseline. So we're going to mark 2 baselines, you know, and if we can't find this one, we're just going to draw a line across. But this is the area. So the machine's going to compare this area, that's the area of the summing potential, to the area of the action potential. And it's going to calculate that for us and give us the, see, here's the area of the action potential alone, right? But we really want to know the difference between these. That makes a lot of sense, and that's going to raise our sensitivity, right? So that's a great feature. Okay, I told you that I couldn't, we're almost done. I told you that I couldn't collect an electrocochleography response in this room. If I was careful, I can get an ABR. I can certainly get a vamp, but I couldn't get an ECOG. Sure, it's the smallest response the human body makes, so you need clean, electrically clean things. And besides that, we got the low filter real low, where the band pass is 10 hertz to say 1500, not 100 hertz, 10 hertz. So what could we do when we have interference like that? This is good for ABR and ECOG, both. Well, one thing we could use is shorter test leads. Notice that on the Tiptrodes, the leads are 40 inches. Maybe not 40 inches, but I think they are. Yeah. And the longer this lead is, the more this is an antenna that's picking up things. Okay? A shorter lead would be better. Okay? They don't come in shorter leads, but shorter leads would be better. Okay? It might take some innovative thing like cutting and splicing this thing, but to give yourself a shorter lead would be helpful. Okay? So shorter leads in general tend to pick up less noise. You could put the 60, if your piece of equipment has a 60 cycle notch filter, you could turn it on and try it. In many, many cases, that'll solve it. Okay. It does take a piece of the pie out. It does diminish the response slightly, but you could get away with it. You couldn't get away with moving the low filter up to 100 or 75 or something, moving it up past 60 cycles. You couldn't get away with that. But the notch filter, if it's a narrow enough notch, you could get away with that if you have to. Otherwise, don't put that on. Sometimes the interference is of a higher frequency. It's not 60 cycle or 120. It's a higher frequency, a multiple of 60 cycles. So you can bring the high-pass filter, if you normally have it at 3,000, bring it down to 1,500. Okay? Naturally, the more narrow the bandpass, the less interference problem. Another thing that's very good, the front end of this equipment are all differential amplifiers. Differential amplifiers are most efficient at rejecting noise when the impedance is equal between left and right. So one ear's 3,000 hertz electrode impedance, and the other ear is 13K. Say one ear's 1K, very good electrode impedance, and the other is pretty bad, say it's 10K. Well, we're not going to get optimal noise rejection out of the differential amplifier. It's called common mode rejection. So to enhance the common mode rejection, make the impedances as equal as possible. Whichever one is higher, scrub better. Okay? Turn the gain down. I was trying to, right before we started this class, I was trying to actually acquire an ECOG response in this room, regardless. And I came pretty close to doing it. I had to turn the gain down. I was actually watching my EEG, and I could see the noise in the EEG. And by turning the gain down, I was actually able to acquire a response. I just couldn't operate with the low filter low enough in this environment. But you could lower the gain a notch if you have to. Don't go down in ECOG. Don't go down past 50,000. You could braid the electrodes. Braiding the electrode wraps the ground electrode around the other two, and it kind of acts as a pseudo shield. Okay. It is a single channel test. If you have it set up as a dual channel test, change to a single channel. All right? Less likely to pick up noise. Watch the lead dress, in other words, so you don't have the Tiptrode lead actually wrapped around or even crossing the transducer. Now you're picking up stimulus artifact. You're inducing stimulus artifact out of here, electromagnetic artifact, right into this lead. Okay? That's no good. So just watch how you have to keep it separated. Sometimes this works wonders. A power line filter. Not a surge protector, that's nothing. A power line filter that goes by the brand name Monster. Okay, you can get it at Best Buy. And what it does is it actually filters the line. So when you have noise and crap on the power line, this cleans it up some. And in some places, that's all we do is plug the equipment into that Monster filter, and presto, like magic. Okay, it's not going to solve every situation, but in many cases, that's all you needed. The thing's less than $100. This is going to extremes. I did it one time. Where was it? Can't remember where in Alabama it was, but there was an AM transmitter right down the street. Okay, not the Gadsden thing. This was a different case. And I couldn't get anything to work. I actually used RF filters. They plug in where you would normally plug the electrodes in. They're ferrite beads. But an RF filter plugs in there, and then you plug the electrode into the filter. Little tiny filter. Could use that. That's only good when it's high frequency interference, like I was getting from this AM transmitter. Okay, won't do anything about 60 cycle. That's these. RF chokes. An RF choke, you can buy them in Radio Shack, and you can actually put them in places like this. You can put them on here. This is the patient cable on this piece of equipment. You can actually put them on here and on here if you wanted to. And they will also reduce as RF passes by them, it'll choke it. That's why it's called an RF choke, ferrite bead. Some amplifiers have a very, very broad, these preamplifiers on ABR units, some have a very, very broad bandwidth, okay? Ridiculous. Like the Nicolay Spirit had a very, very broad bandwidth. We solved problems by making engineering, sending it back to engineering and having them reduce the bandwidth to like 1/4 of what it was originally to overcome noise problems. And of course, if you have older analog equipment, dump it, get the newer digital equipment, because it's like night and day, as you'd expect, as it is with hearing aids, as it is with records versus tapes versus CDs. Digital processing is cleaner, more noise-free. Okay? All right, one more thing. Look at this. This was an ICS Charter EP. Okay? And I say, this unit is noisy, just inherently noisy, design. I got this as a response. I had it hooked up as a normal 2-channel test, and that was my response. Greg knows where this was, right in Duluth, Georgia. Okay? And it's like, yuck. All right? I went to single channel and I got that. Huh? Well, what's the difference between single channel and dual channel, other than you got another set of electrodes coming out of the machine, another set of antennae coming out of the machine that can pick up noise? Well, the ground electrode, when you're doing 2-channel ABRs, ground electrode's right here. Okay? When you're doing a single channel ABR, the ground electrode is over on the opposite ear. If I'm stimulating here, the ground electrode is here. So moving the ground electrode away from the active electrode, which is high forehead, moving it away is what solved that. But that's a design problem in that amplifier, okay? But just to show you some drastic interference. Interference, electrical interference, can make the difference between this, which anybody would call normal, and this, which anybody would call pathology. All right? But it's not. It's crummy design. Okay. So here's Jay Hall's book. The reason I told him that I would advertise his book is because some of these slides came from him. Anyway, you can get it on Amazon. It's great for anybody who wants to learn more about ECOGs. You can. I should have asked you what's this, because now you know that that's an ECOG, and that's an ABR, that's a middle, that's a late. And in case you don't know what J looks like, there we go. Okay, I hope you guys know more about electrocochleography than you did before, and that you, if you're already doing it in your clinic, you can do a better job. And if you're not doing it, this is a good time to start. Here's some more successful ECOGs. This is a piece of art that I bought in Portland, Maine when I was there this summer. And the moose is like the mascot of the state. And this guy is toasting to our success. Yeah. Thanks, guys. That's it.